Excellent. Okay, so to start, I will just give you all a brief background of myself and my organization. Tony gave me a lovely introduction, so thank you so much. I'm Emma Wager. I'm policy analyst at KFF. I'm not a nurse, although my mother and grandmother both were. So KFF stands for Kaiser Family Foundation, and we are, you may have heard of the large health system that's mostly out here on the West Coast, Kaiser Permanente. That's not us. We are actually not affiliated with Kaiser Permanente. We are an independent nonprofit, and we are mostly focused on analysis to better explain the US healthcare system. So we do policy analysis pieces, we do polling, and we have a journalism arm called Kaiser Health News. And our goal is to get this health-related information to journalists and policymakers, as well as the general public. That being said, we are nonpartisan and independent organizations, so we try really hard to be completely factual and completely unbiased in all of our work. We don't do a lot of speculation, and we don't do any advocacy. We can tell you the who and the what and the where and the when. We can't tell you too much about the why or what's lurking behind some of this data because we are so focused on the numbers themselves. And we also can't tell you a lot about what will happen next. We're not really in the prediction business, but we will be there to document it when it does happen. So this is just to give you a brief intro to the data that was used in this analysis. And the cool thing is that this is all government data. This comes from the US Bureau of Labor Statistics, and it's all public. So you could go up and get on the BLS website and look this all up right now if you wanted to. It's completely free and available to anyone on the internet. It mostly comes from the current employment survey, the CES data. That's where we get all of our employment numbers and all of our wage numbers. And that data is published monthly, which is why it's so useful. There's a little bit of a lag. So the most recent data that we have is from February 2022. So March 2022 data is not available yet, and obviously April isn't yet either because we are still in April. So we look at mostly from February 2020 to February 2022, that 2-year span sort of starting right before the pandemic hit as a pre-pandemic snapshot of the healthcare landscape. And then we look at it up into about a month and a half ago. Just a disclaimer that the data from January and February of this year is preliminary. So it's published and it's mostly accurate, but it might change a little bit in the coming months. We also look at job openings and quits, and those are tracked through what's called JOLTS, the Job Opportunity and Labor Turnover Survey, and that's also run from BLS, but that data is a little bit more laggy. It's about 2 months behind. So I think we only have it through January or December of 2021. And this data is stratified by worksite. So we have data for the healthcare sector overall, but then we can also look at it by specific worksite within the healthcare sector. And there's a ton of them. So we decided to focus on 7. These are the sort of 7 big, most important ones. There are others, but they're a lot smaller. And that's too many lines on a chart, so we decided to leave them be. But we're looking at hospitals, which is sort of an overarching category that includes general hospitals, specialty hospitals, and mental health hospitals as well. We're looking at physician offices, which again includes all physician offices, including mental health practitioners. We're looking at outpatient care centers, so urgent care and ambulatory surgery fall into that category. Home health, nursing care facilities and skilled nursing facilities, and community care facilities for the elderly. Those were our 7 categories. And I will warn you that this data is not, unfortunately, stratified by occupation within those categories. So when we look at hospitals, it's everyone who works in a hospital, not just nurses. But that does include a lot of nurses. And it also includes physicians, other providers, admin staff, support staff, and contracted employees as well. So while it doesn't exclusively speak to what's happening in the nursing field, because nurses are a very large proportion of the healthcare sector, it will tell you quite a bit about what is going on in the world of nursing employment, and you'll get to see what's happening in other areas as well. So, kicking it off, we have this chart here, and this is health sector employment by worksite from February of 2020 to February of 2022. And I will tell you that this is not necessarily showing how many employees are in each sector. but how much the sector has grown or shrunk in employment. So we have physician offices up top. That doesn't mean that there's more employees there. It just means that they've had the most growth since February 2020. Obviously, these areas are not all exactly equal in employment. We can look at the colors. These will stay consistent throughout the presentation. So we have nursing care facilities will always be pink. Community care facilities will be purple. You can see these dark blue for physician offices, light blue for outpatient care centers, green for hospitals, light green for home health, etc. And we'll dive a little deeper into this chart now. So the first thing we can see here, obviously, is the very beginning of the pandemic, when it first sort of started to spread in the US. We had this big drop, and it actually occurred in every single sector here. Everywhere sees this drop from February, little drop in March, and then I think we can all remember where we were, April 2020, when everything just sort of fell apart and there were stay-at-home orders and shelter-in-place orders, and a lot of elective procedures were canceled. So you can see that this decline was the largest in physician offices and outpatient care centers and home health as well. Those were the places that saw, the biggest loss of employees in that time. And then you can see hospitals at the top. Hospitals lost 2 to 3% of employees there, which is significant, but they were doing the best in the healthcare sector at that time, especially because there was so much worry about hospital overcrowding and, inefficient staffing and insufficient staffing for the pandemic. We really weren't sure what was going to happen. But now we zoom out a little bit and we can see what's going on right now in early 2022. And we can see that physician offices and outpatient care centers, they are actually above where they were in terms of staffing. Physician offices especially are about 3% above where they were 2 years ago in February 2020. They've made a complete recovery and then some, same with outpatient care. And home health and hospitals have also made, fairly decent recoveries, especially home health when you look at how far down they were. You can say that those are all within about 2% of employment numbers relative to where they were in February of 2020. So that's a fairly decent recovery. Of course, we have a much bigger story here, and that is what's happening in community care facilities for the elderly and nursing care facilities. And employment there has not recovered at all. They had a slower decline right at the beginning of the pandemic, but employment in both of those sectors has been declining basically every month. It seems to have plateaued a little bit starting out in maybe September of 2021, but there's not really any recovery happening, and the declines are really dramatic. I mean, if you look at nursing care facilities, that's a 15% decrease in employment numbers in 2 years. And for elder care, it's about 10%. So that's really huge. And both of those industries were declining in employment very, very slowly during the pandemic, but the pandemic has accelerated it quite a bit. So, of course, the next question when you talk about employment numbers and where they're rising and falling is to talk about wages. So you would think, maybe these elder care facilities, maybe these nursing care facilities are having trouble with staffing because, they're not paying their employees enough and they should start to pay them more. But you would actually see that, here's the wage growth chart from February 2020 to February of 2022. And it really seems like they're paying a lot more than they had been 2 years ago relative to other fields, of course. Similar to the other chart, we're not talking about community care facilities for the elderly, these employees making more than any of these other industries. We're just talking about that their wages have grown more. So if you look right here at the very beginning of the pandemic, you see a spike in these long-term care facilities and home health and the wages that they were paying. And that's where this data gets a little bit tricky, because yes, there was an increase in the average weekly wage earned by an employee in these industries, but that doesn't mean that those employees got raises. It actually indicates that the people who were laid off and removed from the average were the lower wage employees. So the average wage does go up, but we would probably guess that that is not because everyone got a raise. It's because the people who were at the bottom of the group were removed and laid off and no longer had jobs and were no longer counted in the average. So we see that as the interesting effect right off the bat. And it doesn't really happen in some of these acute care facilities. However, these long-term care facilities are sort of able to maintain this growth, and their wages keep going up every month. And this is now actual real wage growth. This is not just employees being laid off from lower end of the spectrum. They're starting to increasing their pay, and increasing their pay by a lot. I mean, we have 20% increases, close to 20% increases in elder care, nursing care, and home health care services relative to where they were before the pandemic. So they're facing staffing shortages, and they're really trying to attract employees in what's becoming a very competitive labor market. And here we also have this fun data point. This is all jobs, not just healthcare, every private job in the US, so every job that's not the government. And you can see where healthcare lies relative to all employment. It's slightly above. So there's actually been more wage growth in healthcare than in the general economy in the last 2 years. However, that doesn't mean that there's been more wage growth everywhere in healthcare. We can see that we have outpatient care here and offices of physicians that have seen slower wage growth, although still fairly substantial at about 6 to 10%. So we saw earlier that these are the two industries that have beyond recovered to where they were before COVID. And so they don't feel the need to offer the super competitive wages to attract staff. They have the staffing levels that they need for the most part. All right, so now we can get into some of this JOLTS data, where we're going to talk about hiring and leaving jobs. And this is a little bit different. This comes from a different survey, so the data is slightly different. Instead of breaking it out by sector, unfortunately, the JOLTS data is much more high level. So we can tell you about just the entire industry of healthcare and social assistance, and that's all healthcare jobs. And it also includes some social workers and some community workers, but those are a very small portion. So it's still mostly a healthcare metric. And job openings tell us who is hiring. So as you can see here, we started off in March and April of 2020 with a big drop here. A lot of people weren't hiring. Healthcare wasn't hiring. The economy as a whole was not hiring even more. It was, not the best time to be looking for a job, but then it slowly begins to rise. And then by about the end of 2020, we've crossed over, and we're now in higher levels than we were before the pandemic. And then 2021 is when job openings really start to take off. And employers are really trying to hire. And we have at the very, very end here, we have January of 2022, 60% increase in job openings in the entire economy from where we were before the pandemic hit. And in health and social assistance, it's almost 70%. So hiring as a whole, the number of open jobs is 70% higher than where it was in February 2020 before COVID happened at all. So it's a really, really competitive labor market. Everyone is trying to hire. People are really trying to get more staff. And then you have the flip side, which is, in my opinion, the most interesting chart of the bunch. So this is job quits. This is people who are leaving their job of their own accord. They're not being laid off. They're not being fired for any reason. They're choosing to leave. And we can see here that, again, at the very beginning of the pandemic, the initial lockdowns, job quits went way down. People really weren't quitting their jobs. And then again, we see this recovery, and then around early 2021, we cross over, and we're now seeing people quit their jobs at higher rates since before COVID. And you may have heard some media talk about the Great Resignation, they're calling it, I believe, which is basically everyone, or quote unquote everyone, is leaving their jobs, quitting their jobs, going to go do something else, going to take a new opportunity, or just not going to work for a while. And we see here that that's pretty true. There's a much higher rate of people quitting their jobs than there has been in recent memory. And if you look at health and social assistance jobs, that's kind of even some months higher than all jobs put together. So we have in November of 2021 saw above a 40% increase in the number of people quitting their jobs each month from before the pandemic. So that's very substantial. And they're currently about 27% higher than they were before the pandemic. So job quits is a really interesting metric because it tells you a lot about how much turnover there is in the labor market, but it doesn't tell you a whole lot about why. And again, like I said, KFF does not do why very much. So we can't tell you if people are leaving their jobs because they want to get another one, maybe one with better pay or better benefits in a competitive market, or if they are leaving the industry, or if they are leaving the workforce. Those are the three reasons people tend to quit jobs, but we can't really tell you if it's one of those reasons that's driving this increase or if it's a combination of all three. So this is something that is going to be very, very interesting to keep an eye on going forward, whether this is a metric that's really related to people changing jobs a lot, which can also drive wages up, or if it's just people are burned out and they're quitting healthcare or they're deciding to go do something else. So that is what I have for my numbers. Thank you guys all for being here. Thank you, Tony and Penny, for having me. And if you want to hear more about this, you can always follow KFF at Twitter. On Twitter, we're just at KFF, or check out our website, kff.org, which has this analysis and a bunch more up there.
Well, thank you, Emma. That's, I guess I would say this data is certainly frightening in many regards. There may be some recovery, but we are still dealing with a real crisis in the healthcare system, and we know how it's very much affecting nursing. So thank you very much. Our next speaker is Kate Cowden, who will address the effects of the pandemic and subsequent nursing shortage by presenting her lived experience. Kate?
Thanks, Tony. Hi, everyone. Like Tony said, I'm Kate Cowden. I am here to kind of share my experience of what it's like being at the bedside during the pandemic. As Tony said in the beginning of my introduction, I am a Regis grad. I'm very fortunate. I had a fantastic experience in nursing school. I had a great education. I scored a job right out of school in a hospital that was everything I could have imagined and more. I started out in our newly licensed nurse program that I always tell my professional development is like the best thing that could have happened to me coming out of school. It gave me confidence. It gave me more education, everything that I could have asked for to start out, support, knowledge, everything. I started out my career on a medical surgical floor. And my career just, took off. It was great. I loved it. I loved my job. I had the greatest coworkers, and, and then 2020 came and COVID hit, and how does really, anyone prepare for a pandemic like that? It was tough because, you learn in school, you go by evidence-based practice. You go by the evidence of what evidence shows and what's the best thing, to do for your patients and everything. And, evidence was just changing so quickly. Everything was changing, week by week, day by day, sometimes in the middle of a shift of, what PPE we're supposed to wear, what we're supposed to be doing, what medications are we supposed to be giving, how long are we supposed to leave the rooms empty before we can put a new patient in? And, it was stressful. I am very lucky that our administration, kept constant contact with us, emails, reaching out to us, coming to the floors, kind of updating us on the policies of what we're supposed to be doing, and you know, our professional development coming to the floor and, you know, making videos of how to take your PPE on and off and how to do it the right way, and overwhelming of how it affected so many people in the hospital, how many different, you know, between the professional development, having to like change gears and, you know, be teaching every nurse what we're supposed to be doing next, and administration trying to tell us, you know, this is what you're supposed to be doing to protect yourself and protect our patients, and you know, trying to support us as, you know, we were having this huge wave of patients come through. You know, it's such a, it's a great feeling to feel so supported in such, you know, trying times. It really is. But, you know, when it comes down to it, you know, we're all just human, and no one really, no nurse educator, no nursing school can really ever prepare you for what we were about to see. It was just this overwhelming quantity and severity of illness that we had never seen before. Every patient that was now being admitted was, you know, being ruled out for COVID. The majority were testing positive for COVID at the time. This was before we had a vaccine. You know, not having the treatment or knowing the definite treatment of how we were going to treat these patients, and, you know, standing outside the room and just like crossing your fingers, you know, giving them everything that we possibly could based on the evidence that we had. FaceTiming families, you know, from the rooms, you know, patients that were, you know, so sick, and they couldn't have their family at their bedside. You know, I could only think about at those times, what it would be like if I was there, like if I was in that position, you know, so sick with something so new that no one knew anything about, and not being able to have my family there, not being able to have my parents or my kids or my siblings. That had to have been petrifying. It definitely for sure emphasized why I wanted to be a nurse, why I'm so passionate about what I do. Because we became the patients' families. You know, we became the people that were holding their hands as they were, you know, unfortunately passing away. We became the people that were the only people they saw for sometimes weeks at a time. You know, they were in the hospital for 2-3 weeks, and all they could do was FaceTime. So, you know, we were the only contact that they had. And that's such a positive thing that came from it, of the connections that I was able to make with these patients and their families. But, you know, it takes a toll on you. Like I said, you know, nobody's superhuman. We all have human emotions, despite, you know, being a nurse or a doctor or any profession. And so, you know, so many nurses were leaving. And it wasn't because they weren't supported by their hospital, or they didn't love being a nurse, or they didn't like taking care of patients anymore. It was just so much to take in emotionally. And we learn in school, you know, try to separate yourself. Don't take it home with you. So it became so difficult to do that, you know, because, you know, you get home and all you could think of was, oh my God, I wonder if they made it through the night. Like, did they make it through the night? Are they going to be there tomorrow when I get back to work? You know, and also coming home to your family. And like Tony said in the beginning introduction, you know, both my parents worked in the healthcare field. So we were all kind of quarantined together. We didn't have to separate ourselves from each other, but going home and wondering, oh my God, am I bringing this home to my parents? Am I bringing this home to my sister? Like, you don't know, like the stress was just so much for so many people. That they were leaving. You know, our older nurses were retiring. You know, nurses that had been there since before I was born were leaving the bedside. They loved the bedside so much that they were there their entire career, and they ended up leaving for the sole fact of the emotional toll. You know, so many of my friends that I graduated with, you so much, we all talk, and so many of us are experience such higher rates of like anxiety and depression and all of this because of everything that we've seen. We have such great supports in our friends and our colleagues and, support systems. And, but watching so many people get so sick so quickly was just beyond overwhelming. It's almost hard to describe sometimes. And, it takes a toll on us, those who stayed, with all of these nurses leaving, having to take on, picking up extra shifts because, we're short, and having to train new staff because we had to hire travelers, to fill the void, trying to support new nurses that were coming in, these poor nursing students that, had to adapt and do clinicals online and coming in and starting their career in such a trying time, and trying to support them and teach them the ways that, we were taught. It was just so much. And like I said, it took a toll. It took a toll on a lot of us. And I think that part of you as a person, like that's why people become nurses, that compassion, that you care so much about these people more than just them as a person or as a patient. Like you care with everything that you have, and watching them pass and watching them get so sick and watching them have all these complications and not knowing how to help in the best way, like just giving them all that you had, but still not knowing if it was going to be enough. It was just heartbreaking. And as someone, I, wear my heart on my sleeve a lot with my patients. Like it took a toll coming home, thinking of these patients, like months later, thinking of these patients and their families and everything. I think was just the biggest impact, talking to my friends and my colleagues, like that was the biggest thing. We had the best support. My, assistant CNO was on the floor in scrubs answering call lights, and our professional development was working overnight shifts. They've worked days their entire life, and they're working overnight to provide support. They're, meeting us at the door when you walk in with breakfast and everything. Like we had the greatest support, and yet we were still just taken down by how ill everyone was. And it broke my heart to say, because to see people that were such amazing nurses like leaving the bedside was tough. There a lot of patients were missing out on nurses that by no fault of anybody's, just they couldn't bear it anymore. And how do you recover from that? I can say, like I said, my experience was a very positive one in such a negative way, if that makes any sense. I was working med surg, like I said, as I started out, and for the majority of the pandemic, but I felt so supported where I was and where I am, by my colleagues, by my, my friends, by everyone, that I actually moved to our ICU recently this February, because I just wanted to follow through, and I wanted to further how much I could care for these patients, how much I could give for these patients, how much I could learn, so that way I could give everything I had for them. As negative as it was with the burnout and the depression and the anxiety and, not being able to leave work at work and taking it home with you, and, how afraid we all were. Like everyone got to stay home. Everyone was so afraid, but they were at home. And here I was getting up, going to work, not knowing what I was getting into or what I was getting into. And I can absolutely admit I was so afraid to go to work some days, but it did reinforce of just how much of an impact nurses can make, how important our role is at the bedside, how important our role is in our patients' lives, how important we are to each other, to our doctors, to our PCAs, to our secretaries, to our transports, how we all came together to continue to fight this. And now, however long out we are now, seeing the people still standing like beside me, like wanting to help, wanting to see it through, wanting to continue is just, that's why I became a nurse, and that's the one thing I kind of hold on to as I continue, as we all continue to face it, is just knowing that, what we're doing for our patients as a whole, the role that I'm playing, despite how hard it is on me coming home, that I'm somehow making a difference. And I'm thankful that I'm able to do that. I'm thankful to have the support that I do so that I'm able to do that. It makes me so much more appreciative for things that, you would never think of before living through this.
Kate, I just want to say to you, your story is so inspirational. And all I can say is, that we were always with you, watching, praying for nurses at the bedside, our frontline heroes. And your story is incredibly heartwarming, but also heartbreaking. So thank you so much for sharing that with us.
Yeah, thank you for having me.
Well, our third speaker now is Dr. Nancy Cowden, who will present one hospital's response to some of the issues that Kate has just described.
Oh my God, Kate, you are just unbelievable. And I don't know how I can't even imagine anybody sort of articulating all the different components that you did. You were absolutely so articulate about the evidence-based practice, changing every minute, the loss of your older colleagues and more experienced colleagues, bringing new people into the workforce, and supporting them, being next to those families as they suffered. It's just, it's such an honor to follow you. Thank you for representing that just so amazingly. And thank you so much, Emma, for setting the table and letting us all really think about the sort of big picture view. And I think my job here is to just sort of give you one hospital's story, and then we'll be able to sort of see the whole thing come full circle. So I'm at Boston Medical Center. It's actually the combination of Boston City Hospital and University Hospital that merged a long time ago now. But actually we did the physical part of the merge just a few years ago. And I think we try to carry both missions, the academic mission, we have a very big resource portfolio, but also take care of the really most vulnerable people in Boston. Here's our little by the numbers. We're about 500 beds, really big outpatient platform. One of the largest emergency departments in the country. We partner a lot with the community health centers, and we have 1,700 RNs. And so if you remember that number, you'll kind of be able to think about the impact that everything that Kate was talking about has had on BMC. So this is a little bit about our patient population, and I bring it forward not only to just show that we are really a strong safety net hospital, but also for us at BMC, we were really disproportionately impacted in the COVID pandemic, especially in the first wave, because so many of our patients were frontline workers that couldn't stay home. They were the truck drivers and the delivery people and the housekeeping staffs and the nursing assistants, and also many of our patients live in congregate living settings. So not only shelters, which I think people heard about, but also just multifamily, multi-generation households. So we had just a very fast surge, and it stayed very, very high as our neighborhoods were really, really impacted in the COVID pandemic. So no question about it. I have been in healthcare a long time. I've been in leadership a long time. You probably can't really see my crow's feet because I'm on Zoom, but trust me, they're there. And this shortage is not like any other shortage, and it is a lot because of exactly what Kate talked about. I don't think we ever have had so much of the workforce at all different parts of their journey impacted as much as we have all been impacted in the last couple of years. We heard Emma talk about, the Great Resignation, and it's like totally true, and it's a national story. And I always use the slide. I want to remind my leadership team and the board of directors that this is broader than just healthcare, but certainly a big story for us. So, I think I used this slide for the board of directors to remind people just kind of about the different pieces for us. We in nursing have been particularly impacted. The 20 months of the COVID pandemic we've seen it at Boston Medical Center sort of in a bimodal impact in our workforce. A lot of our early career nurses, sort of the 2 to 5 year nurses, feeling like they were going to be working, this is after the first surge, so hard anyway, potentially working on the front lines with patients with COVID. And when travel nursing became so lucrative, this was a way for them to say, you know what, I might as well pay off my school loans. Maybe I don't have a family yet here or don't own a house. This is a way for me to be very, very flexible and make a lot of money in a pretty short period of time and really help the parts of the country that need it. I also read a really interesting quote that was in the Harvard Business Review, and it was put into as part of the article that they did talking about nurses across the country. And they had interviewed a lot of travel nurses, and the travel nurses said, one of the things that I can do as a travel nurse that you can't do as a staff nurse is leave. And I thought, wow, so this is like another reason why people may have gone to travel nursing. They could work for 13 weeks, work really hard, and then take a break, which really you can't do in a regular role. So just another way of looking at sort of the travel nurse phenomenon, that people were looking for ways to create space for themselves to heal between assignments. And I have another slide on this too, but just as a marker, we had 2,200 travel nurses in Massachusetts in 2020, in June of 2020. And a month ago, there were 11,700 in Massachusetts. And by the way, I have a bunch of them. But it's really been a very important part of how we have gotten through this is travel nursing, and also just a really different story than travel nursing has been in the past. And I'll talk about that in a second. Let's see. Lost my, there we go. So this slide comes from Emerging RN Leader, and Amanda Oberlees used it in an ONL presentation. And I thought, and Kate covered some of this, but I thought that this was some of the things that are really interesting and different. So new nurse onboarding right now is very challenging. Wearing a mask has changed our world. We can't even see the emotion behind people, and the connections are harder to make. And because a lot of them did miss out on some of their clinical rotations, they're more anxious, they're more nervous, and it's just it's been a different set of needs than we've had in the past. Some of our newer nurses are precepting. And this is exactly what was discussed earlier. Older and more senior people have decreased their hours, changed roles, or left the profession. And that's the bimodal part. We have these new people going into travel nursing and a lot of early retirements at BMC. So both ends of the spectrum being impacted disproportionately in the pandemic. And so therefore you have people who are maybe out 3 or 4 years precepting. It's a lot for them, and they're also in charge, and it's like pushed people forward. And I was thinking about that when I first met Kate, and she was telling me that she went to the ICU. This was a story for us too. A lot of our nurses moved, step-down nurses went to the ICUs, the ICU nurses went to the PACU or into a clinic, and everybody sort of regrouped. The traveler disruption, which is both financially for the hospital and also just, in terms of team. And, I have a lot of travelers in some of my units. Is 25–30% of the nursing staff is travelers. That really changes the dynamics on the floor. Nurse well-being, we could talk about that. It could be its own president's lecture for sure. But that is for sure. It has suffered and is suffering. Experience train we talked about, and just like sort of all of the different things that we've had to change in terms of, you know, no, you can't eat in the break room together. You're too close. You have to eat by yourself. I mean, when I look back and think about it now, it's just like so many things we just piled on that made it more and more challenging for people to cope. So, you know, chief nursing officers are always thinking about workforce, because people move and people change and people have babies and all kinds of things. And so we are always, you know, hiring new grads. We're trying to recruit experienced nurses and thinking about the onboarding of those people, their ongoing professional development in different areas. As the volume is variable, we have to sometimes, you know, increase the numbers of employees that we're hiring. And so this is always a part of our thought process, and always something we're, you know, considering. But definitely we at BMC, we have seen more attrition in the last 18 months. And actually for us, it started about in May or June, and we had more trouble recruiting and a little bit more attrition. And then for some hospitals, including mine, the mandatory vaccine impacted my workforce. I had, I know it doesn't seem very many. We have 1,700 nurses, but we had almost 30 nurses leave. It was heartbreaking for me, heartbreaking. They just could not get the vaccine. And I talked to every one of them, and it was so heartfelt and so strongly held, those beliefs that people had, but they couldn't do it. And it was really sad. But starting in October, November, we started to really see a delta between the people who were leaving and our ability to hire behind them. And that is where at BMC, we saw our travel nurse numbers increase. And I think that was pretty typical in Massachusetts. And so, you know, the other piece for us is that the hospital is very, very busy. So, you know, maybe in other times, if the volume had dipped, we would maybe not need to fill every single position. But because the hospital is so busy, we've had to figure out a way between our own overtime of our own nurses and travel nurses, how we've been able to make sure that we can staff, because that's, of course, the most important thing. And so I got this slide from in a presentation that I was in just the other day, and it is looking at a survey that was done that asks nurses across different settings their likelihood of leaving. And the good thing about this is it's pretty recent. Let me see. I think it was from November of 2021. Big title, Nancy. You can see it there. And so you look at across the board in all the different parts of healthcare, the percentage of people who are looking to leave is, you know, a third, which is just so hard to swallow. And when you look by role, it's also pretty consistent across the board, but nurses, RNs are, you know, at 30%, and nursing assistants are at 27%. And that is really, really high. So for us at BMC, the national demand for nurse travellers has gone up. We currently have, well, when I made the slide, it was 171 open RN positions, and that is almost exactly how many travelers I have. And so it's about 10% of my workforce, RN workforce. And we currently actually have more than 100 people in orientation. We usually hire about 60 new graduates a year. This year, we're on track to hire about 150, and it actually is probably going to be a little bit more than that. And that is because of how difficult it is to hire experienced nurses. And one of the things about that is usually, you know, if an experienced nurse is ready to leave their job, do something different, you know, go into a different part of the hospital, now those nurses who are considering leaving, lots of them are going to travel. So I can't necessarily hire the nurse from Melrose Whitfield Hospital or whatever who wants to come and be an ER nurse. She is probably going to travel instead, or at least right now, because if she's up for leaving, she's considering a higher salary. And so one of the things that's happening for us, we are really looking again at the education supports and the other kind of infrastructure supports that we need to put into place, because so many new graduates and so many novice nurses from nursing homes or whatever, they are on the night shift. And so, you know, we need much more support for the night teams to support those novice nurses. And we are really, really thinking a lot about retention. Turnover has always been expensive. It's especially expensive right now. And so it's not only about recruiting, right? It's really about retention. And for me, that is something I think about so much because I feel like we need to reinvent ourselves. And it is a really exciting time to be in nursing because it challenges us to say, what will it take for us to be able to create for nurses satisfying jobs that help them balance their life and help them stay emotionally strong and be able to connect with their patients. And I think a lot of the way we've, maybe migrated in healthcare, it hasn't been the most healthy. And, our nurses take care of 4 or 5 patients on med-surg. I should have asked Kate this question. Do you go to lunch? Do you give your colleague your 4 patients and do you actually take a break and walk around the hospital? It means somebody else has 9 patients, and that is really not okay for a lot of people. And so a lot of people don't leave the floor, and man, that's not great. This is another a slide that I'm using from my colleagues at Supplemental, and I wanted to point out one specific number about this. Hang on for 1 second. Sorry. There were 28,000 open travel nurse jobs in April of 22, and that is sorry. In April 22 compared to in September of 21 where there are 80,000, right? So last fall, which is what our story was too, last fall was the highest number that we've seen ever in travel nursing. It's already started to come down. And if you can see this map of the country, there's just a couple of states, Massachusetts being one of them, where there's increasing travel needs. But for the most part, they've come way down, and we are starting to see the rates come down too. So from a high that was compared to say $70 or $80 an hour, my kind of whole career, I always thought of it as about the same as time and a half for the top step. Now the hourly rate that we pay as a hospital was up over $200, and of that the travel nurses were getting something in the 160s or 170s for the most part. It's a very different number. So this is BMC data, and I show it to you just for a little contrasting of why one might need travel nurses. So on the left-hand side is the emergency department. The black line is the budgeted number of full-time equivalents. So the number of nurses that you would need to run our emergency department, it's at 180 is the y-axis there. And the red line is the number of permanent hired staff. And you can see starting in May, that number starts to go down, and we aren't able to hire into those positions and make it stay up around the black line. So the dotted line is includes the travelers. So you can see that we have now enough nurses in the emergency department because of the, say, 140 permanent staff that are there, plus the 40, 50 travelers. So that is the highest travel floor I have right now. And that is why. It is because of the, attriting numbers and then the need to pull them back up to their budget. Contrasted with med-surg. So the black line is the budget line. I'm almost hired perfectly on it, which is the red line. But oh dear, we had to add a new line because they actually need many more FTEs than that to meet their current budget. So to meet their current volume. So the travelers, the dotted line, are the ones taking us from the budgeted number and hired number up to where we need to run the surge floors that we're still running, and to run all the extra beds that we need at BMC right now. So I told you that we have seen these increase in retirements. We are really committed, though, to stabilizing the workforce, and we have a lot of initiatives that we're really starting to think through to be able to do that work. So one of them was sort of the 2 top left, the RN pay adjustment and tuition repayment. So the RN pay adjustment, we took our current salary range and we just moved it up to meet the market. We did it in November. It was really effective in the beginning of December of 2021. And that was, we haven't had to do an off-cycle RN adjustment. It affects almost a third of the employees at BMC. So it was a very big decision and a very big thing for us to do. Of course, everybody that was currently working got a pay raise, and then everybody we're able to hire comes in at a more competitive rate. So that's a big one. And then for tuition repayment, this is for people who are still carrying loans. And there's a tax benefit actually this year too. this year and last year. It's able to be pre-tax, which is phenomenal. It's not taxed. I mean, and for those of us who have taken advantage of tuition reimbursement or repayment, that has never been the story. So that was a great thing. And it really affected, of course, the people in the beginning of their career, because those are the people still carrying loans. And then we did some work on a weekend program, weekend only shifts. If you've been in healthcare a while, you might know it as the Baylor program, that sort of idea, and that is to decrease the weekend rotation for our experienced nurses. We have many residency programs going into all our specialties. We started a staff nurse recruitment and retention council to get ideas from them. We have improved our referral program and our landing page, for people who are considering coming to BMC. So this is sort of some of the things that we've already done to strengthen our value proposition. But, and we have a magnet culture. This is the 2 NDNQI scores of how we were able to improve our nursing engagement. We went way up to, outperform the mean, which I'm really proud of, but I don't think it's enough anymore. And so now I am starting to really think about and study with my leadership team and with input from the staff, those things that I think we're going to need to really explore in order to have a long-term success in retaining staff. So just sort of quickly, if you start like on the light blue, we used to rely on travelers to be in 13-week rotations in order to cover like maternity leaves or FMLAs. And I think we may have to change that now if travel nursing doesn't really come down. It's probably more financially a good idea to be able to hire in order to be able to control, for those times when people are on LOA. And on the right of that hiring philosophy, I feel like, people are really needing more time off and needing more LOAs and needing more vacations. And we might just have to hire differently in order to be able to afford people that opportunity without leaving, right? We've done a lot of thinking about onboarding and probably need to do even more to make sure that people have a really good start. Professional growth and development, I could have a whole page under this, but I think, nurses are looking for nuanced change. I'm at the bedside for 36 hours a week. It's almost like handing a baton. I take care of my patient for 12 hours. I hand the baton to the next nurse. And then, what can we offer people for time, indirect time to do quality work or lean work or work on research or work in patient safety or education. You want to teach a PALS course, you want to teach CPR, you want to take 24 hours this month and be able to teach. I really think people need those kinds of opportunities and time away from the bedside to renew and to explore things that they're interested in. I can't say enough about wellness. We have a wonderful council, an integrative therapy council. They gave small aromatherapies to all of the staff. They still are doing Reiki on people and imagery and meditation. And we have one who's a yoga teacher, and there's just never enough, I don't think, wellness for our staff. And so I really want to keep looking at that. Leadership span of control, we haven't really done anything with that, but nursing is we're the only industry that has somebody trying to, coddle and care for and mentor and coach 80 people. So I don't know, I'll be able to move on that one, but I always think about it. Recruitment, obviously, we're also investing in, and patient care support, on the floors. What else can we help? What else can we put in place that lets the nurse spend more time with her patient? There was a quote about how hospitals need to make sure that they value and prioritize clinical interactions for staff, because having therapeutic relationships with patients is what's really feeding nurses. And so how do you make sure nurses get a chance to have more of that and less times when they're distracted and have to do other kinds of things because you don't have the right supports? So I know we're saving questions till the end, but I always like my baby. So thanks so much for everybody's time, and I'm looking forward to hearing what people might ask.
Thanks so much, Nancy. You really did follow the perfect person, and to really tell the story from your perspective. And God bless you that you coddle and care for 80 staff members. I get it. Believe me, I understand that. And but we still love what we do, don't we?
Yeah, it's those people who are coddling the staff that I'm the most worried about, but we do love what we do. Go leadership.
Our next speaker and final speaker is Miss Lisa Stand, who will tell you what is being done at the national level as we continue to move forward. And then what we will do is go into the Q&A, and I will be looking at the chat questions. So again, add your questions to the chat, and I will use that as the basic forum for our questions and answers.
Okay, well, thank you, Tony, for your introduction. And I really sincerely want to thank Regis College for including the American Nurses Association in this really rich discussion this evening. Let me give a minute, and I will try to also get my slides up there. And somebody, let's see, give me a, yeah.
You're good.
It all looks good. I'm
Yep.
going to try to get into a presentation
Yep.
mode. Still
Yep.
look good?
Perfect.
All right, yeah, one last little thing to do. Okay, so yes, so and then before I go on too, I want to thank also Emma and Kate and Nancy, and Kate for your care, Nancy for your leadership, and both of you for giving us a window into your experience. Yes, and Nancy, congratulations on your magnet recognition. So I have titled my talk, Nurses Have Needs Too, and I think that's obvious by now. But I have the subtitle, Policy Priorities and Advocacy to Care for the Nursing Workforce, because I do want to recognize the situation that nurses are in and have been in, while also pointing to some opportunities that we do have collectively to intervene through public policy, and I'd say largely federal policy this evening. So just a little bit about ANA, the American Nurses Association. We represent the interests of the nation's 4.3 million registered nurses. We really have core functions being advocacy and professional development, and an overarching mission to improve the quality of care for all. We also work closely with our state partners and national partners to really be the voice of nursing in one voice. My role is on the policy team within ANA's Department of Policy and Government Affairs. And so my group engages with regulatory agencies and the top program leaders, especially, particularly the Department of Health and Human Services, the Medicare and Medicaid programs, and the Department of Labor, advocating for nurses, their well-being, and in a larger sense, also their ability to provide high quality care. And we also conduct lobbying, voter education, and consultation with state partners. So this is a little bit of what I'm gonna cover this evening. So to care for the nursing workforce, using our policy and advocacy tools, the first question really has to be, how are the nurses doing? And I know we've heard some really good and particular firsthand accounts of that. I'm going to share some of our survey research, which is pretty close to some of the data that Nancy shared as well. And then considering all that we have heard this evening, what public policies can be enacted or changed to strengthen the nursing workforce? And then third, how can you be an advocate if you want to engage and advocate for nurses and really for all healthcare workers? And then underlining all of this, I hope you hear a theme about listening. I think we have been listening, and it's just been tremendous listening to one another. And so I'm going to end with a few words about the ongoing collaborative in the nursing profession to address racism in nursing. It's really critical for us to know that we are hearing all voices in the community in order to deliver the highest quality of care for all. And I know that's a lot, and I talk fast, and so I'll be mindful of the time. But so nurses, how are you doing today? How are you doing at this time when it's the 3rd April in a row of the COVID-19 pandemic? And again, thank you so much to Kate for starting this conversation. ANA and the American Nurse Foundation, which is our sort of sister organization in the larger organization, have been collecting data from nurses about their experiences throughout the pandemic. Our 11 surveys so far in 2 years have guided our responses as an organization to support nurses in all settings, because nurses everywhere have been affected. We also found that policy leaders really have been a very eager and keen audience for this information, especially in the US Congress and 2 administrations. I'm going to focus on our most recent survey, which asked many of the same questions as earlier ones, so we do have some comparison data. And again, it's going to echo some of what you've heard, but certainly not contradict it. Our latest results were released about a month ago. The foundation fielded this survey over 3 weeks in January of this year. We had 12,000 responses. For a deep dive, do visit our survey webpage, and there is a link there, and I know you'll have access to the slides if you don't already. There are tools there to look at segments of this data according to all sorts of topics, demographics certainly, but also setting, states, nursing role, and so on. It's really quite a rich bit of data, and it is publicly available. We're really proud of that. So we did ask also, do you intend to leave your position in the next 6 months? 23% said yes, and another 30% said they might. And that lighter blue area there, that's the not planning to leave. That portion has gotten smaller over time. But drilling down, there really seems to be more to the story. Higher percentages of younger nurses or who identify as Black, African American, or Hispanic or Latino said yes, they plan on leaving in 6 months. Also, higher percentages of nurses who work in acute care, critical, intensive care, and ED nurses said this. So we do see signs of turnover and instability. And this is consistent with what you might have heard in the news and what you heard this evening so far. As with previous surveys, we polled the possible reasons these nurses want to leave. The top 3 in this latest one: insufficient staffing, work is negatively affecting my health and well-being, and lack of support from my employer. This is a national survey. I want to emphasize that. And the type here is very small, I know, but we did see that these sentiments intensified from earlier surveys. It's notable, at least in the overall responses, that leaving for higher income comes in at number 5. So things have not gotten better in the past year. But again, some deeper analysis gives us a little more information about how nurses are doing. The notable point our analysis found was that Black or African American nurses said mainly they would be leaving in order to keep themselves and their families safe, for further education, looking for higher income, and seeking promotion. So we just saw insufficient staffing was the top reason that many wanted to leave. So we also asked, is there an actual staffing shortage where you work? I think this is also not surprising given the data we looked at. 9 out of 10 respondents said yes, and 54% of those said it was a severe shortage. But really, nurses, how are you? We asked questions to explore mental health and burnout symptoms. We found high levels of feeling stressed, frustrated, exhausted, and overwhelmed. We also found higher percentages of nurses in critical intensive care, EDs, and acute care acknowledge these negative feelings, as did younger nurses in a higher percentage. Compared to the earlier surveys, we found that there were increases in nurses who answered that they feel undervalued, they feel unsupported, and even betrayed. So I want to take a brief pause now to acknowledge the resources of the American Nurse Foundation through the Wellbeing Initiative. This is a multi-tiered approach to support nurses experiencing severe stress and trauma, offers safe places to talk, access to self-care tools, and ways to find mental health services. So that's called the Wellbeing Initiative. You can find it if you search ANA Wellbeing, take you right there. And I really encourage you, help us fight stigma that may be haunting a nurse who needs to reach out for help. Which I think is an apt segue to my final point on violence and bullying. So the number of workplace violence incidents against nurses are on the rise, we found in this survey. 2/3 said they have experienced increased bullying at work, while 1/3 report increased incidents of physical violence. Assaults, threats of assault, and bullying in healthcare are unfortunately not rare. 1 in 4 nurses have experienced workplace violence. So this is older ANA survey that I cite there. The Government Accountability Office reported that healthcare workers are 5 times more likely than workers overall to experience violence in the workplace. And we certainly saw increased incidents during the pandemic. And there was quite a lot of media attention there as well. Unfortunately, violence is an occupational safety and health hazard for many, and uniquely so in healthcare. So just for a little recap, nurses are stressed and overwhelmed, don't feel supported, don't feel valued, and are increasingly unsafe, so much so that many of them are thinking of leaving their jobs. And many of these don't work in Massachusetts, I should say. We still don't know everything that there is to know about what's going on in the workforce. I think you heard that too from Emma and from Nancy. Are nurses leaving the profession altogether? Are older nurses retiring sooner than they might otherwise? It sounds like they're localized, that may be true. Will nurses go back to school? Are they looking for jobs in outpatient care? Emma's data is kind of suggestive of that. Will they find those jobs? And some, maybe, but how many? I think that future study is going to help us get a better look at that, but we really don't know. Yet, our survey pretty clearly shows deep dissatisfaction, poor work environments, and feelings that their job right now is a threat to their safety, health, and well-being. And this has to be addressed by the healthcare institutions, like Nancy sounds like she's such a great advocate for her nurses, but also by Congress and the administration. And that's where my work really is focused, because the federal government funds a great deal of our nation's healthcare. So let me go into some policy directions. And the first one is leadership. Since last fall, ANA has been urging the administration to declare a crisis and begin to seriously address the unsustainable situation facing nurses. We offered a number of steps that national leadership could take, most of which I touch on a bit later. They're both short and long-term steps, and they really require multi-stakeholder commitment and consensus building in the space of public policy, we believe. So since the time we sent that letter, we have seen some progress. We should always celebrate when we have policy gains, as they're usually hard fought and long awaited. The Consolidated Appropriations Act for 2022, which was signed by the president just a few weeks ago on March 15th, has more funding for nursing workforce development this year. And this is positive. We hope that we are seeing some momentum build to advance another piece of legislation that hasn't made it through yet, the Future Advancement of Academic Nursing, or the FAN Act, which will significantly fund a very serious effort to modernize nursing education. And there's a lot of support for that, as you can imagine. But all of these are somewhat short-term, or they focus on entry to the profession. And so we also need to make policies that support nurses in practice, so that they will remain and thrive in the healthcare workforce. And that's that retention issue writ large nationally, with a public policy lens. And so for that, we are really convinced that policy solutions have to center on the value of nurses and the care that they provide every day. So that means policies that address mental health in the healthcare workforce. And I note that the Surgeon General is committed to doing this and has started on a program for that. Policies to ensure that hospitals do deploy sufficient nurses to provide the safest and highest quality care to patients. Policies to improve safety on the job, whether that's having appropriate protective gear or addressing the hazards of violence. And we are supporting federal legislation to really accelerate steps to prevent violence in healthcare. The House has passed a bill and we are hoping that the Senate will take it up. And support nurse well-being. So it's not just mental health, it also means schedules that allow healthy amounts of sleep, restrictions on mandatory overtime, and as Nancy mentioned too, letting nurses use their paid sick leave and time off to refresh. And in the broader debates about the healthcare system, where I focus a lot, payment reforms. So just to just very briefly, nursing care shouldn't be considered room and board or overhead. Nursing care is a central part of clinical care teams, especially in inpatient settings, and their work should be valued and compensated accordingly. Optimal patient outcomes depend on nursing quality, and there's a lot of payment being made to health care providers on the basis of quality and outcomes. And so we are really interested in some pretty transformative pay policy changes, and that's going to take a while. Not at all saying I'll be back here with a slide saying that it just passed a year from now. But we need to keep that idea of value up front when we go to Capitol Hill or ask the administration to help nurses where they are now. I believe many other health professionals and providers have a stake in these issues and do stand to gain when nurses are valued. And that brings me to advocacy. So nurses are a very activated group, and you do a very good job making your voices heard. That needs to continue, and voices need to be amplified. It's in the Code of Ethics. So I encourage you to collaborate with us. We have resources for advocacy at the federal and the state level. Also encourage you to stay in touch with your state professional organizations, stay informed, and make sure that your representatives hear from you. Help your members of Congress and your state legislators understand how their decisions affect nurses and care delivery. And we do offer some resources to guide you. We follow Congress very carefully, and we're able to mobilize nurses' voices at key moments and for key votes. Our one-stop advocacy hub is rnaction.org, and I encourage you to go there. You can get our latest health policy news, sign up for action alerts, find your member of Congress, and have some more ideas about how to communicate with policymakers, and much more. So I want to end by highlighting the National Commission to End Racism in Nursing, which is new and just getting started. It will have a policy component, but I think the work is just beginning and the policy piece is not there yet. The commission is led by ANA as the convener, along with the National Black Nurses Association, the National Coalition of Ethnic Minority Nurse Associations, and the National Association of Hispanic Nurses, with numerous other groups as members. It was launched in 2021 to explore racism in nursing, and not just explore it, but ultimately create a national action plan to guide diversity and equity and inclusion efforts within the profession. As part of its work, last October, the commission launched its first national survey. They had 5,600 respondents asking questions about experience with racism in nursing and or witnessing racism and impacts. So results were released this past January. More than 3/4 of Black nurses said that racism in the workplace has negatively impacted their well-being. 63% of nurses said that they have personally experienced an act of racism in the workplace from either a peer or patients or a manager or supervisor. And to me, these findings really validate how the commission has defined racism as assaults on the human spirit in the form of biases, prejudices, and an ideology of superiority, which persistently causes moral suffering and perpetuates injustices and inequities. Full findings and other information are available on our website, which we're relaunching shortly, but I also encourage you to go there and learn more about this project. And I want to thank you for listening and for being here, and I really look forward to the discussion.
Thank you so much, Lisa. What an amazing wrap up for us in that regard. And it gives us some tools or some ideas about what we can do going forward. I think Nancy as well brought forward some ideas of what somebody in healthcare leadership is attempting to do to transform the way nursing practices, as well as how the workplace needs to be somewhat transformed for us to come out of this crisis. And stay out of the crisis. Well, now we're going to move to the chat, and I'm going to open the chat up for myself so I can see. I believe some of the questions now. I need some help, I think. Wait a minute. I'm going to go back to the top.
I can answer the first one that was directed at me.
Did you? Well, there's a question here that was asked if, and I think it was aimed to Emily, oh my gosh, yes. And basically the question is, do you think the wages that we saw that are growing would be due to the fact that there are so many more travel nurses that are being employed? Does that affect that, Emma, that number that you were talking about in terms of wages going up?
It certainly could. We just do not have any data to point one way or the other, unfortunately. Nurses are sort of taken as a whole in most of this census data, and they don't really split out travel nurses versus facility nurses at all, unfortunately.
Nancy, did you want to add anything to that? What are your thoughts?
No, I think when I look at the overall spend in Boston Medical Center, which is up a lot of money, this is my microcosm, not compared to Emma's national data, but definitely the expenses, a lot higher, just because the individual FTEs are paid at almost 4 times our usual rate. So I think it could be that. I think that the question asker probably could have been right about part of that.
Yeah, okay. And Emma, there's a second question for you, and it's asking a question regarding the geriatric population, and whether the geriatric, we in geriatrics are concerned that the wage growth in this sector currently going on is secondary to Biden's stimulus bill. There is a Medicaid section which allows funds to be used to increase compensation for staff, but often they're doing that as bonuses, so baseline salaries are not going up with any increase proportionately. So are you familiar with that?
I'm familiar with the change in payment, yeah. I can't speak to how that's the payment policies of individual organizations are affecting this data, just because I don't have that information, but it's certainly a possibility.
Okay. Anyone else? Lisa, what are your thoughts on that one?
Yeah, no, I do think, I mean, it was well understood that the stimulus funding, was sort of a one-off, and that's a business decision that probably a lot of providers made, and how they were going to spend it on workforce. Yeah, but I don't really know. I don't have specifics, and I do think that, well, in long-term care, what we have found, or what we believe to be the case, is really a lot of the staffing crunch is really in the non-nursing staff. And while we would like to see more RNs in nursing homes, that's it's usually not the case, except for perhaps a director.
So it's the paraprofessionals, the nurses' aides that.
Right.
This is, and it's always been difficult myself coming from the field of gerontology, we've always been challenged in the staffing, especially of the paraprofessional. And they're just amazing. They're gifted people in general, but this has done them in a great way. I have another comment that is actually, I'm going to put this to Nancy, since Nancy was talking about creative ways for retention and recruiting and bringing young people into the profession. The question is, would a sabbatical be something to be considered as well, to allow people to get that needed break in order to keep them from completely leaving the profession?
Yeah, we've even used that word, sabbatical. I think the challenge is it's going to be a financial one, right? Because you have 1,000 nurses or 1,700 nurses or whatever, and you can do the math on your phone, but if you took everybody and gave them a 1 month or 2 month or some number sabbatical and it was paid, which I think is what you're kind of probably suggesting, you are quickly into millions and millions and millions of dollars. And I'm going to sort of jump to also, Debbie Roy asked me about what is my favorite staffing and retention strategy? And I think I will say that to me, it's a little bit of a Maslow's hierarchy for this, right? The very bottom is you have got to pay people competitively. You really, nothing else will work if you don't have a decent compensation plan. That's one thing. And it doesn't have to be the highest, but it has to be in the range. And then for me, the second thing is staffing. I just feel like if you don't have, and it's not, I've also started to make a distinction. It's not just safe staffing, it's satisfying staffing. So if you don't have good staffing all the time, that will eat away at a staff nurse faster than anything else. So you start with the right compensation, then you have the right staffing plan. And then you do some of those magnet tenants. You make sure people have a voice in the practice. You make sure that they can contribute to the practice environment, make sure that they have good teamwork and collaboration, and that they can take great care of their patients. And then you start to get into some of the creative things that I was thinking about. And I think my favorite one is providing for people opportunities for them to either walk in another person's shoes in a different department or participate on something that is meaningful to them professionally. And so they get time away from their bedside that is paid, where they can, experience different kinds of things that are exciting to them or interesting to them. I feel like I'm going to land on that being one of the important things that we do differently in the next couple of years.
Kate, I was thinking, what are your thoughts on what Nancy's saying?
I can't emphasize enough on what she's saying about satisfying staffing, not just safe staffing. It's hard. So like I said, let me clarify too, most of my experience in COVID was on a med surg floor. So you're very typical 1-to-4, 1-to-5 patient ratio. But there are days that, you have call outs, you have sick calls, you have, short staffing, more stressful shift. We try so hard to have, like our resource where our charge nurse out of assignment. And as someone that has been in that role, being a charge nurse, being your resource nurse for the floor, being an assignment, and having to, kind of run the floor, support the whole staff, and have your own assignment and provide for your patients, stressful, and I know that's across the country that's an ongoing thing. The staffing and the efforts to just keep staffing at a sustainable rate is just the biggest thing. And the biggest thing to keep nurses, because the more support you have, the more staff you have, the less stressful your assignment, the more likely you are to stay where you are.
Yeah, it's kind of a chicken and the egg, right? It's that, Nancy, you're right. That's got to be the priority, and everything else will start to fall into place. Nancy, there's another question here for you. Wondering if BMC uses a lot of NPs, and what are you seeing with regard to vacancies regarding the nurses in advanced practice?
Yeah, I saw that question, and we do have a lot of nurse practitioners at Boston Medical Center, but most of them are in provider roles, so in outpatient clinics as a provider. And we haven't seen the same kind of attrition in our providers in general or in the NPs. And I'm wondering if they just don't quite feel as mobile as nurses do. They have their own panel, they have their relationships with their patients, and maybe they don't feel like, that it's quite as easy to leave. I think that's possible. And I have not seen that. One of the other parts of that question was, have I seen nurse practitioners go become staff nurses for the salary? I have not seen that. I'm sure it's happened, but I haven't seen it myself. The other comment I wanted to make about nurse practitioners, since I have the mic, is I feel, and this is really for Lisa too, and for the larger advocacy. I think that hospitals should be paid for nurse practitioner education like we're paid for medical education. It's just horrible that nurse practitioners have to find their own preceptor, and at BMC, our nurse practitioners have to precept out of the goodness of their heart. We don't give them any RVU relief or time or anything, and it's a really big struggle. And for a lot of nurse practitioners, especially direct entry ones, they need a great experience. And I just feel like this is a place where we haven't done the right thing by our NPs. We need them. They're so critical. Look at the Institute of Medicine report. Look how much we're counting on them to expand healthcare access, but we don't provide for a way for them to really get a good clinical orientation. So I think that's one of the other things I want to work on.
Yeah, Nancy, you're on it, because that is a continuous challenge for producing and educating and bringing into practice the advanced practice nurse, because we have no resources to pay preceptors, whereas in medicine, there is Medicare money that's passed through to educate docs at the bedside. So I think you're absolutely right. This is an investment that needs to be made in the best interest of our country. Well, that's a good one. We'll keep on that. We've talked about that for years, and maybe it's time, Lisa. Maybe it's time.
Well, I hear you. And yes, it comes up quite a lot. And there was another question also about, being able to get into training programs and, really get that hands-on, earlier in training, or, we have a lot of hospitals who just stopped having students in for the past 2 years too. And so, there's some catching up to do, even at, in the RN level. But yes, I mean, and I think just as an advocacy tip, I think that is the difference between how medical education and training is financed and how nursing training is financed is pretty big difference. And I don't think it's always in the forefront of policymakers' minds. I mean, I think, they probably know it in some level, but it's what the impacts are and how that really plays out is something that, should be putting in your messages because it's a pretty big deal. There was a pilot a number of years ago that just gave hospitals, or gave schools, I guess, money to just have a staff person who, finds preceptor roles in the community and in hospitals and in schools, and, in a really rounded way. And it was very successful, but it was pilot money, and it was not reappropriated. So there are, maybe that's sort of somewhere halfway to talk about, is expanding that G&E program.
Mm-hmm. Mm-hmm. There's a question here, which I think is interesting, which I'll let anybody respond to, talking about reinstituting the 3-year hospital-based nursing programs. Do you dare, Nancy?
Oh, geez, the entry into practice argument. Oh, so, well, I'll tell you that, and this is a little bit linked with Lisa's commentary about racism and opportunities for nurses, of color. And I think the 2-year program, so not the 3 for a second, but just the 2-year programs allow for entry into nursing for a much more diverse group of nursing applicants than a 4-year program would. And so I believe strongly in the ability for people to get an associate's degree, and then quickly go to Regis and finish their bachelor's. Because I think it's a very fast jump into the middle class. And I think the unintended consequence of requiring a bachelor's for employment is that you will have a less diverse workforce. And I just feel like it's just kind of how it is. So I think the person who was asking about the 3-year program was really mostly thinking about how practical it was, because the nurses in those early programs, those hospital-based programs, they got so much clinical to the point where they were staffing the hospitals, which I could use that. But I think, I feel like, we have to reinvent ourselves on the hospital side. And I feel like we have to work differently with the schools of nursing. I wonder if a 1-year residency when a nurse gets out of nursing school is the way to handle that kind of a thing. So that literally, and I mean, we have residency programs, but not like that, not where we really invest in their real deep learning and partner with the school. Maybe that senior year is a combination, of didactic and real hospital-based experience. So maybe I don't think we should exactly go back, but I feel like going forward could look a lot like that. And so I think the question is a really good one.
There has to be greater investment, both for both the school and the practice setting, to really be able to partner better with regard to transition into practice.
Yes.
And the handoff is, we have some precepting, but then we do this quick handoff, but there could be much more collaboration.
A handoff, you basically throw them at us. I'm just kidding.
Thanks a lot, Nancy. Okay, I have a question for Kate, and let me see if I've got this straight. I might need some help here. Wait a minute. These chats are not always easy to keep track of here. Kate, do you have any sense of how your nurse friends have recovered at this time? Do you see nurses seeking the support they need?
That's a great question. So yes and no. I think that I can only speak on behalf of people that I've spoken to and myself, have reached out, and definitely I think people are going to, using our, support groups at work, using support groups outside of the workplace. I think a lot of nurses are, acknowledging the struggle with their mental health. And, I'm a huge advocate for it, of people going to therapy, and, there's different routes for that, like in terms of like one-on-one therapy. And I've found a lot of my friends have sought help in mental health professionals just to cope with what they're seeing and how to, continue on in their daily life with how it is. I think the support groups that are out there, I think, you start to appreciate coming from a school like Regis, where your support group is so strong, even far after graduating. The friends that I made at Regis, the professors that I had relationships with that continued on, I think we're all relying on one another hugely right now to make it through. I'm a huge advocate, like I said, for everyone getting help with, the mental health challenges that are coming a lot. It's a lot more frequent now with nurses with this going on. But I think the biggest thing is relying on one another, having your friends to call after shifts to talk about, cry with them, whatever you have to do. Nursing is one of the biggest, such a camaraderie, even if it's a breakdown, you'd be surprised how many nurses cry in the break room or the bathroom or the galley where the kitchen is, and then you turn around and you're right back out there. But just having that person there, and so I would say the biggest thing is relying on your colleagues, your friends, and reaching out to help when you feel like, if that's appropriate for you.
Thank you, Kate. Nance, there's another question here. You had described that nurses need additional clinical resources to help them now. What did you mean by that?
Oh, sorry if I skipped over too quickly. What I meant was we are finding that the nurses that we were hiring, the new graduate nurses, many of them missed at least 2 semesters of clinical and some 3. And so we find that when they come into the practice environment, our typical orientations are not working. And so what we did historically was we put them through like a 5-day nursing orientation, like a didactic kind of a program. Then we'd put them with a preceptor. And what we found is the preceptors, it was just overwhelming for the preceptor because the new nurse, they just hadn't done enough nursing assessments. They just hadn't done enough, they hadn't had a lot of experiences. And so now what we're doing is we're kind of transitioning so that we have more like a faculty model. So the new nurses are in small groups, let's say like 4, with an educator, not a preceptor, an educator for 2 weeks on 8-hour shifts. And during those 2 weeks, they take like 1 patient, the 4 of them, or maybe 2 patients, and they give the meds, they do head to toe assessment. The educator tries to really make sure that they feel solid in the basics, and then we give them to the preceptor. And we're also hoping this will help with preceptor burnout, because the preceptors are trying to also care for patients and it's just too much. So Kate, you should come work at BMC. This is what I'm saying. I'm saying you nod. I want you to work.
I would love to jump in on this topic really quick.
I was kidding. But anyway, that's what I meant. We're having to retool orientation in order to support the new nurses who have had really truncated education because of COVID.
And if I could just jump off of what Nancy was saying in terms of, I feel like this just shows the importance of having these NLN programs, these newly licensed nurse programs, these new grad programs. I always joke with my professional development that I'm like their biggest hype man, because I had such an amazing experience where I'm surprised that it's not more, across the board, that every new grad has this, where I had, my hospital orientation, then my nursing orientation, my EPIC training. And then I had, 2 weeks of just straight classes with just one-on-one with a small group of us, with our nursing educators. And then, my orientation time, but it didn't end with that. The first couple of weeks, you still had a class in and amongst your time on the floor. And then it slowly weaned you off until, even after you were off orientation on your own, I can't even remember what the exact timing was. You still had a class following that. You still checked in with them. And I think it's just really important to have these supports, especially for these nurses that are coming in that are missed out on a lot of their clinical experience.
And Kate, did you find that those classes, when you were pulled back together, that they were also like a way for you to provide support for each other, like a kind of?
Oh, absolutely. It was like a little therapy session. We're like, oh my God, we saw this today. Oh my God, you saw this. Wait. And we're like, wait, what did you do? How did you do that? And they're like, oh, like to share the experience of what to do. Like I said, I worked on a medical surgical floor, and there were some nurses that were on just a surgical floor. And I'm like, wait, what? You saw what? And you did what? And, you only see so much in clinical. And I was lucky enough to have like a full clinical experience, let alone these nurses that are coming in with online clinicals, Yeah, for sure. Absolutely. I think the cohorts that you start with add to that support system. Yeah.
Kate, I know that you haven't mentioned it yet, and I didn't even have it in my introduction to you, but could you share with us where you're working?
Oh, yes. So I work at Brigham and Women's Faulkner Hospital over in JP. Yep.
All right. That's a good, you've been saying such wonderful things. I think it's important for us to
share. Yes.
brag a little bit about the wonderful organization you're working for. Nancy, I think you kind of answered the next question, so we'll move on. And I've got Lisa. How do we increase the number of nurse preceptors? That's something that Nancy actually just touched on, so that we can prepare our future generations. And again, that may tie into funding, where there can actually be some funding to support preceptors, not necessarily giving them cash, but that they can actually have a less of a load, so they can, be able to offer more. But what are your thoughts about that?
Yeah, no, I mean, it is gonna come down to that, I think. Yes, but beyond that too, I think that not all hospitals, are really operate in a way that promotes that kind of, knowledge transfer and experience. It's not resource, but it's also just not sort of part of the culture. When we talk about valuing nurses, that's what we're talking about. It's ensuring a certain, professional treatment, on the care team, and, really elevating and lifting that up. And I know that's a lot, and it's not going to happen overnight, but we certainly, when we talk about value, it's a lot that as well. And so where, experienced advanced practice nurses would want to fulfill that role because it's, they're enabled to do it, and, it's part of the, it's part of the role.
Mhm.
So that funding has a lot to do with it, but it's also, making those demands and
Mhm.
changing the culture.
I think, I remember my first preceptor. I think everybody remembers their preceptor, right? There's like nothing more important in the beginning of your career than your preceptor. And so I think the other things is just as a leader to recognize how important that role is, invest in your preceptors and bring them together and develop them. Sometimes, you can pay, it's never going to be enough money, but at least it's a gesture to show how important that role is. And they need to be thanked, and they need to be supported by the director on the floor. And you need to appreciate them. They're doing their own work, plus they're doing your work, right? To onboard and to create a culture in the unit that is, satisfying for people to work in. It's a really important job.
Mhm.
I agree, Nancy. I will say, as someone who has precepted many of new grads, it's a big role. It's a big role to take on. It's an honor to be asked of that to think that your professional development team thinks so highly of you to train somebody coming in. And I think one of the biggest things and the biggest challenges that we faced with COVID was bringing in so many new nurses, bringing in so many travelers, bringing in so many new people. We did not have enough preceptors to go around. So you'd finish precepting and you'd have like one day of being back to yourself. And then it was like, hey, so you want to precept someone else? Of course, like I love it. I could talk all day long. So I love having someone to work alongside. And but still, then with, like, as I was talking about before, some of the older nurses, more experienced nurses were leaving. So now we're relying on nurses who are 3-6 months off orientation, being like, hey, so you want to teach someone that's fresh out of school that never has been in a hospital before?
Right.
And as one of the nurses that I precepted was asked to do this, and I actually, she's probably mad at me for it, I volunteered her because she was just such a strong nurse. And she's like, well, how am I supposed to do this? And it was just this constant struggle of trying to find people that could continue to train these new nurses and precept these new nurses.
Yeah. There's also the whole issue of immigration and foreign nurses. Is that something that people are tapping into now as well? I know we've done that in the past when we've had shortages. This is much different than what I can recall ever in the past, but is that something that hospitals are looking at in other settings as well?
I'll just speak for myself. I remember we did a lot of international recruitment in the early 80s, in mid 80s, late 80s. And I know there was specific programs that the government put forward that made it a little bit more straightforward for the nurse to take the language exam and then be able to take the NCLEX. There are specific recruiting agencies that recruit in specific countries that you can partner with. But I haven't really heard, we aren't doing it, and I have not heard about my colleagues doing that either. So I don't know if Lisa has more insight, but that hasn't been something we've been talking about in Boston.
Yeah, it doesn't come up a real lot. I mean, it's acknowledged. I think there was some, discussion about, that paperwork kind of got held up with travel restrictions and the rest. And so there were some, some advocates were at least, wanting to kind of cut through that. But our view is, that there are a lot of countries that lose nurses that they need. And, there is, it's a global workforce issue. And so we don't have much of a position on relying on foreign trained.
And one thing I will say is it's not good for equity, because the wealthier countries pull from the other countries, and like we pull from England, or with pull from the Philippines and whatever, and then they pull from Africa, and
Yeah, you're actually advancing the brain drain in countries that really can't afford to have that. So
exactly.
you're absolutely right. You're absolutely
Yeah,
right.
it comes down to money, and the richer countries win, and so.
Well, we have the opportunity. We have a little bit more time. Are there any questions? If you want to raise your hand for any other question that someone that hasn't put it in the chat would have. And I can't, you're going to have to help me if you see a hand go up.
I'm just going to respond to Philip Mallison, who wrote in the chat, what about BSN programs partnering with hospitals to advance those who graduate from ASN programs? And I'm sure Tony can talk about this, but the baccalaureate programs have partnered with a lot of the associate's degree programs. Almost all those associate's degree programs, or maybe all of them, have matriculating agreements,
articulation agreements.
Yeah. So that the person has a really smooth road to their baccalaureate. And we actually also support that. We have a bunch of different program connections with when the person's employed. So I think we've done a good job. And I do feel like nursing has come a long way in this and made the ASN to BSN road way more
seamless,
sort of
much more
straightforward
seamless. Yeah.
than it used to be. Yeah.
Yeah, much more seamless. All right, well, now I'm going to ask Penny if she wants to jump in, but I did want to let you know that that now that we've heard from everyone, and we've certainly, I think, had some wonderful, wonderful discussion afterwards, don't forget that the evaluation link will be posted in the chat room and will remain there until 8:45. So if you want to get your CEUs, if you want to get academic credit, please be sure you complete the evaluation link. And I really want to thank all four of you for your incredible contribution to this event this evening. As I said earlier, you have all been amazing panelists, and I actually don't want the conversation to end. So we could probably be here for many more hours. In any event, I want to say thank you again to all four of you. And I want to thank Penny and her team for their incredible leadership, for putting such a comprehensive, such an informative and timely program for all of us this evening.
Tony, thank you so much. I really appreciate it. And I know the team does as well. And you did an awesome job as moderator.
Thank you.
It was really good. So I think with that, we can turn it over to Kayla, who will put the link into the chat, and everybody can fill out the evaluation. And keep us in mind for September. We will have 2 more presentations in the fall. And I hope you'll attend that as well. And thank you again to the panelists. And that's it. Thank you so much.
Thank you. Have a nice evening.
You too.
Thank you.
Bye-bye.
Thanks, everybody.
Thanks for having us.
It's a pleasure.